Myocyte depolarization starts with an influx of sodium through a voltage-gated sodium channel. This is followed by a brief efflux of potassium, followed by the simultaneous influx of calcium, balanced by the efflux of potassium, generating the plateau phase of the myocyte action potential, followed by the opening of several additional voltage-gated potassium channels, resulting in the repolarization of the cardiac myocyte. One of the important channels for maintaining the resting membrane potential of the cardiac myocyte is not voltage-gated, but nucleotide-gated, specifically by ATP and ADP. When ATP is abundant, the channel remains closed, helping to maintain an extracellular potassium concentration of just 4 millimole, compared to the intracellular concentration of 155 millimole. When these two concentrations are funneled through the Nernst equation, a resting membrane potential of about negative 85 millivolts falls out. During ischemia, ADP predominates, resulting in the opening of the K-ATP channel. Now, when the increased extracellular concentration of potassium goes from 4 millimole to 10 millimole, when it's funneled through the Nernst equation, a new resting membrane potential of negative 60 millivolts falls out. Importantly, the plateau phase of the myocyte action potential falls. As time progresses and the cell is deprived of more oxygen, the extracellular potassium concentration continues to rise to almost 20 millimole. This results in an even higher resting membrane potential and an even lower plateau potential. Flat isoelectric segments of the ECG waveform occur when there is no electric gradient between overlapping myocardial action potentials. Under normal physiologic conditions, in the absence of ischemia, this tends to produce the PR and TP segments, seen here in yellow, and the ST segment, seen here in red. Since ischemic myocardial cells have higher resting membrane potentials and lower plateau potentials than their non-ischemic myocardial neighbors, a current is generated by the electric gradient. From the perspective of the ECG electrode, in the setting of subendocardial ischemia, the first myocardial tissue it sees is the non-ischemic myocardium, whose corresponding action potential starts off more negative than its non-ischemic neighbor. This reverses during the plateau phase of the action potential, where the ischemic myocardial plateau potential is more negative than the non-ischemic plateau potential. This reverses once again at the end of the myocardial action potential, as the ischemic resting membrane potential is more positive than the non-ischemic resting membrane potential. The current produced by these electric gradients always flows from more positive to more negative. The current is referred to as the current of injury. When the current of injury travels toward the ECG electrode, it shifts the ECG tracing upward. When the current of injury travels away from the electrode, it shifts the ECG tracing downward. The ECG machine then attempts to zero the tracing along the TP segment. The net result in the setting of subendocardial ischemia is an ST segment depression. In the setting of transmural ischemia, the perspective of the ECG electrode reverses. Now, the first myocardial tissue it sees is the ischemic myocardium. Consequently, now the current of injury runs away from the electrode at the beginning of the action potential, resulting in a downward shift of the ECG tracing. Once again, the current reverses during the plateau phase, resulting in an upward shift of the ECG tracing, and reverses once more at the end of the action potential, producing the characteristic elevation of the ST segment associated with STEMIs. Due to the three-dimensional nature of the vector of injury, we can anticipate that the ST segment elevations and depressions will correspond to leads overlying regions of infarcted myocardium. This produces the characteristic patterns we associate with anterior, inferior, lateral, and posterior STEMIs.